Welcome, everyone. We'll just give a minute for everyone to join. So good morning, good afternoon, good evening, everyone. Welcome to today's EPI-WIN webinar. It's the 35th EPI-WIN webinar of the year, and it's on a very important topic right now, which is Rift Valley fever and community protection, gaps, needs, and priorities. We're very grateful actually that we have some wonderful speakers today. So you will hear the welcome remarks from Dr. Kai von Harbu, Unit Head Community Protection and Resilience at WHO, just after we do the housekeeping and announcements. Then today's moderator for the technical session is Dr. Nina Gobat, who's the Evidence and Analytics Lead for WHO. We will have an update on RVF and what is happening, the current outbreak, by Alejandra Costa, the scientist with hemorrhagic fevers. And then the most exciting part is the panel discussion led by Dr. Gobat. And for that, we have Dr. Albert Gautier Jincheong from the Emergency Response Team in Senegal. We have Mameyachin Modji from the Institute Pasteur in Senegal. We have Dr. Shaka, who's a One Health specialist from Rwanda, and Dr. Mathirio Fall, who's the head of animal health protection in Senegal. So very different perspectives, and we'll have a very interesting discussion. As usual, we'd love to hear from you. So please tell us where you're from, what you're doing in the chat box. And we'd love to hear your insights too. So please add that in the chat box. But if you have any questions for our speakers, and I really hope you do, please put it in the Q&A box. That helps us keep track of the questions and helps us pick them up and answer them more, in a systematic manner. And we do have interpretation today. We have interpretation in French. So for those of you who would like to listen in French or in English, you go to the bottom of your Zoom. There's this globe sign there, which is on interpretation. And then you choose the language that you'd like to listen in. So I hope you will really enjoy this webinar and you will participate in it to the fullest. And with that, but before I hand over to Kai for the welcome remarks, just one final word. We are here to share our knowledge with each other. We believe in positive contribution, and all of you are very welcome to contribute positively. We welcome hearing from you. But please keep your comments respectful and to the topic. And for those who don't, we will unfortunately, if there's anything disrespectful, we will have to take you out of this webinar. But I hope it will not come to that. We're just delighted that you've all been able to join us. And with that, I would like to request Dr. Kai von Harbu to give the opening welcome remarks.
Great, thank you very much, Supriya, and welcome from me and also on behalf of our director, Dr. Stella Chungong from the Health Emergency Preparedness Department. To all of you, the panelists, the participants joining us today, it's a real pleasure to open this very important EPI-WIN webinar for us on a very pertinent topic at the moment, Rift Valley fever. And of course, we will focus here on the community protection aspects of this response. As you know, while we meet today, communities in Senegal and Mauritania are facing a very serious RVF outbreak that has affected both humans and animals across multiple districts along the Senegal River Valley. The impacts are devastating, not only in terms of cases and deaths, but also the wider ripple effects on livelihoods, food security, and social stability. And Rift Valley fever, like many zoonotic diseases, remind us that outbreaks are not just biological events. They are deeply social, economic, and environmental crises. People's exposure and vulnerability are shaped by where and how they live, their livelihoods, and their trust in authorities, and the options they have to protect themselves. And what we are seeing in both countries really reflects that intersection between the environment, livelihoods, and behavior. There are floods creating mosquito breeding sites. There are animal health systems that are stretched. There are communities deeply dependent on livestock for income and survival. And these realities shape the transmission dynamics as much as the virus itself. And this is why these outbreaks don't just challenge our health system, they test the resilience of entire communities. And that's why this response cannot be limited to veterinary and lab capacities alone. It must also address how people understand, experience, and act upon risk in their daily life. And because of this context, community protection is such a critical component of the outbreak response. And community protection is much broader than any single technical area. It's the outcome of community-centered health emergency management. And that integrates community engagement and communication, community-based surveillance and early warning, health service continuity and accessibility, livelihood and social protection, and local leadership and governance. And from all of these aspects, we will hear today in the panel discussion. But Rift Valley fever also highlights the importance of community evidence, understanding what drives people's behaviors, what shapes their risk perceptions, what barriers they face in acting on public health advice, and the wider social and economic impacts of this outbreak. Without this evidence to guide public health action, even the best technical intervention can fall short. And this is really what WHO's role is here, is to provide the evidence base to community protection. And this integrated approach is also reflected in our community protection framework, but also in our broader health emergency preparedness, response, and resilience, or HAPA framework, where community protection is a core subsystem along surveillance, coordination, access to countermeasures, etc. And in this context, of Rift Valley fever, that means strengthening coordination across public health and animal health and agriculture and social protection sectors, that full One Health continuum. And we will hear a lot about that also in the panel today. So we will hear some excellent examples from Senegal and from Rwanda on all of these different aspects on how we can collectively strengthen community protection in response to this outbreak. And there's a lot that can be learned and applied also to other emergencies. So I really look forward to that discussion. Thank you once again for joining, and back to you, Supriya.
Thank you very much, Kai, for that introduction. Now, before we start the technical session, those who are regulars on EPI-WIN will know, we'd like to hear from you. What do you know about Rift Valley fever? And actually, this is very important for us. The feedback that you give in Slido gives us an idea of what these webinars mean, what you think, and it helps us design our webinars better to help you. So the first one is slido.com #8124845. In one or two words, what does community protection mean to you in the context of zoonotic outbreaks like Rift Valley fever? Let me get some responses. Information, education, One Health, veterinary health measures, community engagement, empowerment. But vector control comes on strong, One Health comes on strong. One Health approach, empowerment, mosquito control, vector control, vaccination, empowerment, early detection, virology. Oh, so it's clear. One Health approach, education, vector control, community awareness. Those are some of the major things coming out here. Fantastic. Okay, we now have another question. Please keep the responses coming. Maybe we'll wait a little longer for this slide. We have now 67 responses. We'd like to have at least 100 of you responding here. So come on, please do respond. A few more of you. Okay, I will now go on to our next question in the interest of time, but the Slido will be open throughout the webinar, so please don't stop writing just because it's not showing on the screen. Our next question is about what you know about Rift Valley fever. So it's a multiple choice question. How would you rate your current knowledge of Rift Valley fever? I've never heard of it. I've heard of it, but don't know much. I know the basics. I'm familiar with the topic. I work on this area. Okay, so most of you know the basics and you're familiar with the topic. 38%. There are very few of it. I think there's no one who's never heard of it, but most of you are familiar with the topic and know the basics. Great. I'll stop here for the screen, but please continue to give your responses at slido.com, hashtag 8124845. It's also in the chat. And with that, I'd like to invite Dr. Nina Gobat, the lead for evidence and analytics at Community Protection in WHO, to please lead the technical session. And over to you, Nina.
Thanks so much, Supriya, and also thanks to Kai for those opening remarks that really set the scene for our discussions today. And a very warm welcome to you all, and thank you to you for taking the time to join us. I'm really delighted that we're having this conversation. You know, we all know how much of the real work of outbreak response happens at community level. That's where trust is built. That's where people make daily choices about prevention and control. And that's where resilience really takes shape. And yet, despite this, despite the fact that we know this, community level work hasn't and doesn't always get the same attention as some of the more biomedical or technical aspects of the response. And so today is really about closing that gap. It's about shining a light on what's needed locally and hearing directly from people who are working day to day to support communities at risk or affected by the current outbreak. So without any further ado, I'm going to hand over to our technical expert, to Dr. Alejandro Costa, who's a scientist, our WHO technical expert in the viral hemorrhagic fever team. And Alejandro, it's over to you to give us some background on Rift Valley fever, to increase our knowledge from the basics to perhaps a little bit more, and to give us an update on the current outbreak. Ale, over to you.
Thank you very much, Nina. I'm sharing my screen. I hope you can see it. Can you see my screen? Okay. So I will go to the presentation mode. Good morning, good afternoon, good evening, everybody. Thank you very much for joining this webinar. I will go through a few slides to present you an overview of the disease, how the disease is transmitted, and how we can control the disease and outbreaks. So the main objectives of this presentation is to describe the symptoms and the transmission, as I said, of the Rift Valley fever, and to list the main prevention and control measures, and also to describe the areas of Rift Valley fever as a public health concern. So Rift Valley fever is a zoonotic disease affecting mainly animals, the livestock, and is transmitted to humans through blood or the organs when people prepare the meat. And this is transmitted by a mosquito among the animals and can also infect the humans. 98% of the people show symptoms and are asymptomatic, and only 2% has severe disease. Human-to-human transmission has not been demonstrated. There is no evidence of transmission among the humans. So as you see here in the map, this disease mainly affects countries in the East Africa and West Africa, and also in the South. That has been reported imported cases as well in some countries in Asia. So if we need to talk about the burden of this disease, we can estimate about 1 million people that is at risk in these countries in Sub-Saharan Africa. And also, as it was mentioned by Kai in the introduction, it has a huge burden, economic burden, because it affects livestock, and this stop the exportation of meat and also animals. In terms of transmission, as it was mentioned in the very beginning, this affects mainly livestock, animals, domestic animals, and that are the diseases transmitted, the virus is transmitted by mosquitoes, Aedes aegypti, and also the mosquitoes can transmit to the humans. But mainly, the main infection is when during the slaughtering or butchering activities to prepare the meat, that the disease is transmitted to humans, and there is no human-to-human transmission. So the incubation period of this disease is between 2 to 6 days. And as I said before, 80% of the cases are asymptomatic, and only 2% of the cases are severe in 3 different complications: ocular disease, meningoencephalitis, or hemorrhagic fever in the more severe cases. So the clinical features of the disease, most of the symptoms are mild in the very beginning. During the incubation period, you can see as the symptoms as a flu-like fever, with some mild symptoms like headaches or muscle pain and general malaise. But after the peak of the viremia, you can have more detectable specific symptoms in the severe disease after 4 or 7 days, especially when you have the hemorrhagic fever. So the ocular lesions are more or less one of the symptoms that we mostly occur, as well with the meningoencephalitis. But the hemorrhagic phase is the most severe when the case fatality rate is very high. So the clinical diagnosis is very difficult because in the very beginning, during the incubation period, or in the phase that are mild symptoms, I can be confused with other diseases. These symptoms are sharing with several diseases, and the only way to diagnose this disease is when you have differential diagnosis in the lab with other that you can differentiate with other viral hemorrhagic fevers. And in most of these countries, there is a co-infection with malaria or other diseases like cholera, meningitis, and yellow fever as well. So it's very important, it's essential during the diagnosis phase is to have the history of the patient. If this is on the activities, the professional activities like a veterinary professionals, or if people living in the places where this disease is endemic, or when there is an outbreak. So this information is very important to pick up the cases, especially when they are asymptomatic. So the most common test used for the confirmation is the PCR and also the antibody detection, that in the beginning of the very beginning of the disease, it could be a high titer of IgM and then IgG. For the clinical management, it's like other hemorrhagic fevers when the patients require hospitalization, is to get the right balance of electrolytes and to avoid renal failure or liver failure. So, and the therapy is to stop coagulation if the disease is in the hemorrhagic phase. The drug therapy is mostly painkillers and antiemetics and anxiolytics if the person is uncomfortable. There is no recommendation for other antiviral drugs. For the time being, there is no specific treatment. There are several drugs that have been tested, but none of them has demonstrated efficacy because it's difficult to organize a randomized clinical trial in the middle of an outbreak. But there are several plans to test different antivirals that have been used for other hemorrhagic fevers. So the key components of the outbreak control, of course, is to control the outbreak in animals and also to avoid transmission between the animals to humans, especially when there is slaughtering or butchering practices, and also at home to cook the meat. So this is a more detailed slides on all the activities related to the control of the outbreaks. But as you can see, the participation of the community is very important, especially in the behavioral and social interventions to change if we have an ongoing outbreak, to start protecting the community from the meat when it's not well cooked, or when they have different practices that can lead to increase the transmission. Of course, I forgot to mention that there are some measures as well to control the vector, and I will come back to this in the later slides. So in terms of community engagement, of course, we promote to stop movement of animals and try to detect the disease in the animals. That is very important, and also to provide some education in terms of the meat preparation and to have a safe food. In terms of avoiding infection, we have, of course, hygiene practices as for all infectious diseases. So when you prepare the meat, or when there are some slaughtering activities, to use protection, personal protection equipment, to wash your hands, and also to minimize the contact with blood and organs of sick animals. And when you cook the food, to have all well cooked the food from animals. In terms of avoiding contact with mosquitoes, the same practice as we have for other diseases that are transmitted by the vector, by the Aedes. So we have to use insecticides, repellents, and also trying to avoid being outdoor, or using light colors and pants and long sleeve shirts. but most important is to use the bed nets when you're sleeping. So in terms of vaccination, it was mentioned during the presentation, there is an effective vaccine to vaccinate the livestock, but the vaccination is important to prevent the disease. During the outbreak, it's not recommended because you can increase the transmission between the animals, especially in veterinary settings. The vaccination is used the same needle because it's an automatic syringe to vaccinate the livestock. There is no evidence of human-to-human transmission, so you have the IPC practices, the link here in this slide that you can consult in terms of people exposed at risk, especially veterinary personnel or the people working in the lab. The main challenge is to control these outbreaks. As I said in the very beginning, most of the cases are asymptomatic, so you don't know that the virus is circulating. But when the outbreak is detected in animals, there is an important sign to start the community engagement to participate and control the outbreak. It has a large economic impact, especially in countries that are this activity, the agricultural activities are essential. And so there is a risk of transmission across the borders if the meat or the animals are exported. So you can see in our websites, we have a lot of information. I will advise you to, if you have more interest in very specific topics, to consult our webpage. We have technical information, fact sheet, disease outbreak news, and all the updated the current outbreaks like now in Mauritania and Senegal. Of course, you have information as well on the website of our the colleagues in other organizations, FAO and OIE. So that's all. My colleague Anaïs Legan is the focal point for this disease in our viral hemorrhagic fever team. So you have there her email address if you need to ask specific questions. Now I don't know if I can give some few a short update on what is going on in Senegal and Mauritania.
Thanks, Ale. I think it would be helpful to have a short update. I am mindful of time, but I think very helpful for folks to just get a sense of what's happening regarding this outbreak. Thank you.
So I will be very brief, just to show the number of cases and the epidemiological situation in both countries. In Senegal, as the 9th of November, we have 424 human cases confirmed and with 30 deaths, which is a case fatality rate of 7%. This is mostly affected the north of Senegal, the Saint Louis district, and is in the border with Mauritania. So as you can see here, the peak of the epidemic was on the October 6th, that week, and now the trend is at a decreasing number of cases. And the highest, of course, case fatality rate is in the very beginning of the outbreak, because the cases seeking care attention in the hospital come very late, in the latest phase of the disease. So, and this is a map showing the number of cases in animals, and is more or less the same as the human cases, with the most affected areas in the north. In Mauritania, we have less reported number of cases. Surveillance has been improved in the latest weeks. We have a total of, see now the slide, 52 confirmed cases and 15 deaths. And the case fatality rate is very high, but perhaps there are co-infections there. There is an outbreak of dengue as well. So there is a mission in Mauritania now trying to help the Minister of Health. And also WHO is supporting Senegal in different activities as we do in every outbreak, coordination, and also the community engagement, lab support, supplies, and different activities. So I will stop here and I'm happy to answer questions. Thank you, Nina. Over to you.
Ale, thank you so much for taking time to give us that overview, both to give us a crash course on Rift Valley fever and what that is, as well as to give us some of the information about the current outbreak. There are indeed a number of questions for you in the question and answer section. I'm not going to take those live in the interests of time. I'd like to move on to the panel, but would invite you, if you are able, just to have a look and respond to those directly. I also see folks raising a number of course, the tougher challenges, things like multisectoral coordination, things like actually hearing community voices when issues are raised. And I think these are some of the things that we very much hope will come to the surface as we move to our panel discussion. But thank you, Ale, and we look forward to hearing from you later in terms of your reflections of some of the key, particularly evidence gaps that are needed to help manage the current outbreak related to community-centered practice. But at this point, I'm going to shift the technical session to the panel and welcome our four panelists who Supriya introduced at the start of this session. And I'm going to invite them, please, to turn on their camera. Dr. Njon, Mamiya Mboji, Dr. Shaika, and Dr. Fall, each of whom have a huge amount of experience, including direct field experience of RVF outbreaks, including the current outbreak. And so looking forward to hearing from them. Panelists, as I told you in advance, I'm going to invite you, each one of you, to sort of take a few moments to share with us some of your work and some of your experience. And Dr. Njon, I'd like to start with you, please. You have been working in the fields during the current outbreak in Senegal. You're a socioanthropologist, and you have been bringing that expertise in your work. Tell us about what you have been seeing as some of the key issues related to the ways that communities are responding. Over to you.
Merci beaucoup.
Thank you. Thank you very much for this invitation. As you've said, I will now share with you my experience as a social anthropologist as part of the current outbreak in Saint-Louis in the north of Senegal. This experience I'm sharing will also be sometimes enriched by former experiences in previous emergencies in Senegal since 2014. I work with the WHO and Africa CDC team, which is at the heart of health operations in Senegal. It is a multidisciplinary team which was set up in Senegal and several countries in Africa. I also take part in training other teams in Africa. Within this team, my role is to bring my perspective as a social anthropologist so that the health response can be appropriate culturally and acceptable socially. In my work, very often, I integrate the anthropologic network for emerging epidemics. It brings together several anthropologists, sociologists who work on outbreaks. In the field, more specifically, I work in 3 areas. First, I work on trying to understand the socio-cultural context, local practices, relations with animals and with vectors, popular beliefs. But I also take part in analyzing community perceptions of the disease. and I take part in identifying levers, barriers to the acceptance of health measures. In the current context, with the RVF outbreak in Saint Louis, I worked with the RCCE team because there were many gaps at this level. Why is it important to consider this community approach? I will use two examples to answer this question. And hopefully this will show the importance of this approach. First, in Saint Louis, in mid-October, with the outbreak, there was a lot of skepticism, generalized skepticism. Populations would often say they have now created a new disease. They always do that. They always create some new disease. As part of the arguments used, there was, if the disease really existed, the government would have vaccinated livestock. Additionally, the ban on consuming milk and meat would lead to social and economic distress. People would say, what are we going to eat? What are we going to do? That's all we got. Those restrictions were a direct threat on the livelihood of the communities that we talked to. Secondly, community health actors, including the Bajenogo, who are godmothers, so to speak, as well as community intermediaries who are very important in this context, had not been trained on the disease. And one of those community actors said, I have a radio show and I was asked about the disease and I did not know what to respond. So I just said the same things that I said during the COVID pandemic. So they were asked legitimate questions, but they did not know how to answer. And finally, I would just add that without this community related dimension, the response might not be adapted socially, even though from a technical point of view, the response is very good. And so it would be doomed to failure in a context where populations live with their animals, where people have been drinking uncooked milk for decades and ignoring the community dimension is a threat for the response. Thank you.
And grand merci, very, very many thanks, Dr. Njon. Incredibly helpful perspectives. And I've got questions for you, but I will come. We will come back to you. I'd like to invite Mam Yassine to join the panel discussion and to share with us some of your work. Mam Yassine, you're also working in Senegal, and your focus at the moment is on community-based surveillance to strengthen early detection and community-level reporting. Please share with us some of your experiences. What are you seeing? What are you hearing? What are some of the key community issues that you are experiencing? Mam Yassine, over to you.
Thank you very much, Dr. Nina. Good afternoon, everyone. Thank you, Dr. Albert Dion. He's a big brother for me. I'm a social anthropologist at the Public Health Department at Institut Pasteur in Dakar. I will tell you a bit about what we do in the face of this RVF outbreak. At the Institut Pasteur, in our division to strengthen health systems, we have created a community-based surveillance system which integrates 4S surveillance system, which is a network which is part of efforts to strengthen surveillance activities in collaboration with the Minister of Health. We've been doing that since 2012. It is also a tool that complements surveillance, helping to identify health events that are uncommon and so that the response can be quicker. This approach is limited to health facilities, hospitals, health centers, etc. Within our division, since December 2024, we have created a community-based surveillance systems with community actors who are those neighborhood godmothers, those badjenogors, with community intermediaries and people who provide care at the homes of patients. We have integrated the One Health aspect as well with human health, cattle breeding, and the environment. Specifically, we have informed community actors on the various zoonoses, including the Rift Valley fever. They were trained on this disease. So they have clear, simple cases, simple information, for instance, flu-like fevers, joint pains, etc. So they have been trained with very simple definitions and things that they can see in the field. Sometimes they are complications with hemorrhagic cases, for instance. So they were also asked to flag any case of abortion in animals. To do that, they were trained on an app called HECAP, an app they can use for real-time notifications. If they suspect that there is a case of Rift Valley fever, they can go on the app and they can send a notification, and the chief nurse will then automatically receive this report and they can follow up. Before validating the notification, this community actor can also wait that the person could go to a health facility. So the community actor can look at the information, they can check with the patient if the case is matching the data before confirming the case based on the standard definition. Since the beginning, we received notifications on Rift Valley fever through the apps. So we have received 158 notifications from community actors. 100 notifications were reviewed, 95 correspond to the definition, which means that the community actors understand the community definition of the fever, and 75 cases match the standard definition. There were also some samples taken in this context. Since the beginning, there have been no positive cases of Rift Valley fever in humans. There were cases in animals, 3 confirmed cases in animals. Out of those samples, since they are definitions that were provided to the community actors, there were 6 cases of dengue identified. I also forgot to mention that this model is used in 3 regions of Senegal: in the north, Amatam, in the southeast, in Kédougou, and in Dakar, near Pikine. There is also a lot of awareness raising on Rift Valley fever. When going to the houses of patients, they can also detect or identify suspected cases so that they can maybe be confirmed with the institute. Since the start of the outbreak, community actors do a lot more. When we heard about the outbreak, we went to the various sites to give them a refresher on the definition of the disease. Following that, there were more awareness-raising measures by those community actors, discussions with the populations. They went to the populations to raise awareness themselves. When they did that, they could also report abortion cases in cattle. There were 4 cases of abortion in the north, in the southeast, and in Dakar as well. So I can say that to this day, there are 3 positive cases of RVF in animals detected by community actors. Thank you.
Yeah, thank you so much for sharing that important work, and it's an impressive system that you have. I've got a number of questions for you around, the challenges that you might be encountering around early, notification, community notifications, as well as, possible scale across to other countries. But I'm going to hold back on those questions for now. Perhaps you could give some thought to them. I'd like to bring in our next speaker, Dr. Sheaka, who is going to speak to us from a different perspective, a different part of the continent, from Rwanda, and also drawing on his experience and expertise from responding to earlier outbreaks of Rift Valley fever. Dr. Sheaka, over to you. Be grateful to hear your reflections based on the incredible work that you've been doing in Rwanda in past outbreaks regarding what you see as the critical importance of community-centered work. Why is it so important to be working at community level? Over to you.
Thanks a lot. I hope you can hear me well.
Loud and clear.
Thank you for the opportunity to share experience from Rwanda. As you said, Dr. Nina, I am Ansel Meshaka, an assistant professor in the Center for One Health at the University of Global Health Equity in Rwanda. So our work on Rift Valley fever in Rwanda focuses mainly on tracking new cases and tracking the virus where it hides, especially during these periods where we don't have outbreaks. We have set up sentinel family farms, especially in high-risk areas, with, of course, an objective to have an integrated surveillance involving humans, animals, and the vector. But as you understand, to be successful, it's very important to understand how communities experience and respond to such zoonotic threats, and how that understanding can actually be transformed into prevention and resilience. So I'm going to provide my inputs basing on what we observed during the 2018 and 2022 Rift Valley fever outbreaks in Rwanda. So in 2018, we had an outbreak of Rift Valley fever. I'm starting with this outbreak because this was the first major outbreak we have had, although we had reported cases since 2012. So this 2018 outbreak was happened actually in the eastern province of Rwanda, just near the borders with Tanzania to the east and Burundi to the east-south. This outbreak was not very well managed, partly because the community was not part of the solutions. Back then, we conducted some survey with the affected communities, and we found that actually over 70% of men and 60% of women, of course, had heard about Rift Valley fever, but fewer than half knew it could infect humans, and only about 1 in 5 had vaccinated their animals, despite available vaccines and despite prior campaigns. Now, we moved with the 2022 outbreak. This one was even more severe because it spread to the whole surface of Rwanda, which was different from previous outbreak, which were mainly concentrated to the eastern province. So in 2022, the outbreak affected as many as 173 humans, including 22 deaths. Alongside, we confirmed nearly 1,400 animal cases, including massive 1,200 abortions in livestock species. Now, the management of this particular outbreak in 2022 was really different. Drawing on lessons from the COVID response, the national coordination adopted what we locally call command posts. These command posts are multi-sectoral teams, which were set up at district and central level for case detection, contact tracing, and reporting, enabling the central level to take appropriate decision in a timely manner. But for this command post to function, they really needed information from the community. So the information on new cases flowed upward from communities through community health workers, community animal health workers, and other local informants to district command posts. This command post at the district level had the task to relay the information to the central command post. Now, the central team mobilized the resources and technical support based on the information coming straight from the community. And again, we are relying on the rural community to adopt and implement control measures. So this structure, this command posts transformed the response from top-down to participatory, assuring fast communication and strong local ownership of interventions. And this makes a lot of sense because, as you all know, communities are the first to see abortions. They're the first to know where mosquito breeding sites are. They're the first to see livestock death. And they even notice this often days before formal surveillance detected them. So the point here is when the community is part of structures such as command posts, the reporting and interventions such as vaccination accelerate actually dramatically. The problem for this kind of structure to be successful, we need all actors across the livestock value chains to be trained, to have proper knowledge, attitude, and practices around zoonoses such as Rift Valley fever. We are now working with partners, especially the Capacitating One Health in Southern and Eastern Africa project, which is funded by EU, to develop a teaching platform dedicated to Rift Valley fever. This platform will host content for different audiences, such as simple visual modules for rural farmers, but also intermediate and advanced training for professionals and policy brief for decision makers. The goal is to keep the communities, practitioners, and policymakers informed and connected, not just during outbreaks, but also when the cases are not reported. Just concluding, with our team, we think the community is not the end point of outbreak control. It's the starting point. And tools, including digital tools, can help keep that partnership even beyond outbreaks. I thank you very much.
Dr. Shaka, thank you so much for those reflections. A really excellent example, and one that I'm thinking, would be very helpful to amplify further. And again, this issue of coordination, how to strengthen coordination, multi-sectoral working, absolutely critical. Thank you for sharing your expertise. I'm going to move across now to Dr. Fall. I'm also mindful of time, and I'm going to ask the permission of everybody who's here, our panelists, as well as those online, to give us a bit of extra time. We will run the webinar a little bit longer than the full hour. but I'm also aware that there's a lot to surface. But Dr. Fall, over to you. I'm very interested to hear your reflections as a veterinarian, as a senior veterinarian working in the Ministry of Agriculture in Senegal. What is your perspective on the critical role of community-centered work, working at community level? Over to you, Dr. Fall.
Good day or good evening to all. I would like to thank the organisers for having given us the opportunity to share with you our experience on RVF, but also an opportunity to gather information from your experiences. I'm an epidemiologist and a vet, and I work at the Directorate of Veterinary Services in Senegal. RVF is an endemic disease in Senegal in animals with outbreaks in the risk period of the year, which is the last quarter. Risk maps have been established by the government, and one should recall that in the preparatory phase, the One Health approach was developed with contingency plans. But we've also worked extensively on simulation exercises for RVF in Senegal. When we speak of RVF, one needs to bear in mind that the starting point is animals. It's a zoonosis, and all professionals and experts who work with animals are at the very heart of response. What we have done is that all response activities, be it vaccination, because Senegal chose vaccination, because we had a contingency stock that we used for vaccinations in the high-risk areas. Then there's also communication, awareness raising of breeders who are part of the high-risk populations, along with all people who work in the slaughterhouses. All of these players are, we believe, at the very heart of response, and without those players, none of our activities would have been effective. Breeders, who are also at the heart of this response, have an absolutely vital role to play. In particular, in terms of keeping an eye on abortions. The events always start within the communities, in particular abortions, and this leads to an ability for communities to carry out early case detection. There are also the services that work closely with the communities and who can carry out early case detection at community level. All of this will lead to adequate care of all these cases. Also, in the case of case finding, support is provided to all people who are closely involved with animals, and awareness raising is carried out, in particular with the herders who need to be informed of the disease. The communities allowed for the establishment of the adequate measures, including isolation of sick animals. They assisted us a lot as well in limiting the spread of the disease. Then there is the immunization of the herds, using repellents against mosquitoes, and managing abortions. All of these were vital to the to controlling disease transmission. To conclude, the key to success rests on communities. To be successful, we need to focus on their practices and promote an inclusive and participatory approach. This is what I wanted to mention regarding this disease. Thank you so much for your attention.
Un grand merci. Very, very many thanks. Incredibly helpful to hear your perspective and to hear the range of community actors that you see, that you are engaged with, and that of course are critical to engage in tackling Rift Valley fever prevention and control. I am mindful of how much richness there has been in the reflections from all of our panelists and how much more there is to say and to unpack about this topic. So I very much feel that we are at the start of a conversation that we need to continue very openly and very publicly in some way. I do not want to end this panel, though, without asking you my second question. And so I will ask each panelist to give me your, I was going to give you 2 to 3, but I'm going to ask you to give me 1 to 2, your top evidence gap. You know, what evidence do you feel you need at community level that would really make a difference to the way that this current outbreak is being managed, or indeed future outbreaks might be managed? And Dr. Gauthier, I'm going to come to you first.
Thank you very much. It would be difficult. I had prepared 3 very relevant aspects, but I just pick one. I'll talk about the importance of taking into account the knowledge of communities in the One Health approach. In outbreaks like this, there is this very close link between communities and their livestock. But what we tend to forget, and what I've also understood in my previous interventions, communities have ethnic and veterinarian knowledge, which is very sophisticated. They can identify several diseases, and they have their own ways to treat those diseases, and they've seen for a long time that livestock does abortions at specific times, but this knowledge is not used enough in the response. When there is an emergency, we should be able to document and value local knowledge on animal health in order to develop early warning systems and participatory systems. This is something that was said by my colleague, Mame Yassine. In Kédougou and Dakar, what's being done is a good starting point, something that could be done in other regions, including in Saint-Louis. And one thing that I would like to recall in 30 seconds, we talk about raising awareness among communities, but this is an idea that does not work, because when you take this perspective, you put yourself in a position where you have the knowledge that you will convey, that you will give to communities that know nothing, but it's the other way around. And we need to change this paradigm, and we need to talk about collaboration and true collaboration. So I hope I picked the right example. So this is one which was relevant for me. Thank you.
Fantastic. Thank you so much, and so well said. I don't want to close down your other 2. So if they are not mentioned by other panelists, by the time we come to the end, I will come back to you and ask you just to give them to us in a few moments. Dr. Mame Yassine, over to you. And let's build on each other. So if a priority has already been mentioned, then pick another. Dr. Mami Yassin, what would you see as a priority evidence gap from your side?
Thank you very much. Afterwards, I would like to answer the question regarding the challenges and scaling up.
Alors, je pense que maintenant, I think we probably don't have time to go into the details of it, but I think it's a very relevant question. And I actually wondered whether you have evidence around that. So perhaps it is something that folds into this discussion, but over to you.
All right, I will pick one point. One of the main challenges is referencing cases. For instance, if our community actor reports a suspected case of RVF, if the person is over 50 kilometers away from the health center, they are financial challenges.
Mm.
There is also an issue with the geographical accessibility. It's difficult to go to the health post. Earlier, I mentioned 158 cases, 100 of which were reviewed. For the rest, it wasn't possible for the person to go to the health post so that a nurse can check the case against the definition. So there's a need for an improvement here. Now, regarding the question that was asked regarding scaling up, we are in the pilot phase for now. The goal is to have 3 more sites every year as part of this 4S's approach. Every year, we follow this cycle, and it's also done in other African countries. So in the coming years, we want to implement this approach in other countries. But first of all, the goal is to implement it in regions where there is this 4S's. Thank you.
Fantastic. Alors ça, c'est très clair. And I think that also there isn't a huge amount to learn around what you've already experienced with your pilot sites and what that might mean then in the implementation of further sites. So really look forward to tracking that further. And again, we'll try to come back, depending on the time, how much allowance I'll be given to sort of extend the session to hear some of your other priorities. But Dr. Shayaka, over to you. I know I've asked for 3, but your number 1 priority, evidence gap at community level, what would you say?
Thanks a lot for this. It's difficult to choose among the 3 ones, but let me try. I would go with a socioeconomic impact analysis of Rift Valley fever outbreaks. I'm saying this because most of the interventions and documentation of outbreak tend to really not focus at that particular part. But again, we know that outbreaks disrupt household income, they stop livestock trade, they disrupt food supply, and yet these losses are never quantified and documented. I honestly think that by conducting systematic socio-economic assessments disaggregated by gender and livelihood type when possible, that would help government and partners justify early investment in prevention, compensation, and livelihood recovery. So to me, this is even the efficient way to put our community at the center of the interventions that we carry out. Thank you so much.
Fantastic, super clear. Thank you so much. So pleased you mentioned that, because that is, of course, a key theme that we heard across all of your reflections. Dr. Fall, I will come to you. Your number 1 evidence gap at community level.
I believe that there is a something that we included in our action plan. And based on the investigation that we do within communities, one gap would be the use of a biosecurity manual handbook, which is based on the knowledge of breeders, herders, practices on how they manage abortion, because we have realized that there are gaps in the management of the biosafety of livestock. And we will start very quickly to work with communities to develop this handbook. This is a very important aspect among many others, but as you've said, we just had one gap to mention. So that's the one that I wanted to share. Thank you.
Thank you so much. And of course, now I'm very curious to know what the other gaps are. So I'm just going to get a quick steer from the central team on how much longer we can continue. If we can have another round. Supriya, thumbs up, thumbs down.
The speakers, how long they would be able to stay, and
Okay.
we do have some participants dropping out, but we have more than 400 online. So thank you very much to all those of you who have stayed on.
Fantastic. Okay, great. Then I will ask all of the speakers if there is another burning priority that you would like to bring to the floor. Please do. Dr. Gauthier, over to you.
Thank you very much for this second chance. I believe that they are also specific demands that are based on experience. Community actors tell us that they are things that we should use in the context of an outbreak because it works very well. For instance, our data showed that integrated interventions work better. For instance, when you combine information on Rift Valley fever with other activities such as providing vitamin A supplements, removal of parasites, or distributing mosquito nets, there is better support and people see the advantages. So it's important to develop integrated packages which include Rift Valley fever prevention and other value-added services, which include training on how to cook and store milk in a safe way instead of just banning it, for instance. That's one important aspect, I believe.
Fantastic, thank you. So I think you're moving in the direction of co-developed interventions, integrated interventions that are co-developed and worked through with communities. Really great, thank you. And Dr. Mam Yassin, any addition from your side?
Yes, the motivation of the players for the sustainability of the project. They are volunteers. You need to be aware of them. Now, when I say motivation, it could be financial or not. They have mobile phones in the context of this project. So they have their mobiles, and the project makes them available and pays for the calls and notifications through the platform. So we're in a pilot phase. So if there could be issues related to the sustainability of the project because of this situation. So what we've done to try and motivate them is to cover their health insurance. We've enrolled them on health insurance along with their family and members so that they can at least have health coverage. Even if they're over 20 kilometers away, they can travel to be treated. Then the other issue is the rapid diagnostic tests, which are not available for there to be sampling to check whether there is any RVF or not. Thank you.
Thank you. Thank you very much. Thank you so much. We're making notes here. Dr. Shiaka, over to you.
Thanks. Maybe what I can add to my early intervention, you remember I talked about command posts, which were mainly community-led initiatives, especially at the local level, taking information about cases and transmitting the information to the district level and then to central level. What I can add is we need to have sustainable ways of engaging our community. Usually we have these community command posts, which are very, very active and doing a fantastic job during the outbreaks. And when we don't have cases, this structure disappear. So we would need really to think of mechanisms of having, active structure which can be able to do similar fantastic jobs, even when the cases are not many or even when the cases are apparently absent. So I think this kind of mechanism can help, foster a strong engagement of the community and especially be ready to, report cases even before the formal surveillance systems notice them.
Fantastic. Thank you so much. So strengthening existing systems in anticipation, strengthening the preparedness work. And Dr. Fall, finally, over to you. And this will be our last intervention of the session. Any other top burning priorities in terms of evidence gaps that you would add to the list?
D'accord.
In addition to what's already been said by others, I think it's mainly regarding those who raise animals and who travel. I think as soon as there is movement, then we have an issue. We have some key players who can help us with awareness raising and communication and so on. It's mainly private vets, because private vets are the ones who follow the herds and they already have a special close relationship, one of trust, with the people who work in husbandry, and so they are a main contact and allow for more inclusive and participatory approach. Then there are other players that we could call on to strengthen or control measures, implementation of the activities in the posts. Thank you. That's what I had to add.
Fantastic. Thank you so much. And on that note, I really want to thank all of our panelists as well as our WHO expert, Alejandro. Thank you so much for your time. Thank you for allowing us to run over time. I think it was really important to be capturing your perspectives and your additional reflections. A very big thank you to everybody who has stayed and who has continued to listen into these discussions and been so active in the chat. At this point, I will say a very big thank you from me and hand back to the central team, to Cypria, to close the meeting. Cypria, over to you.
Thank you very much. And I echo from the EPI-WIN team what Nina said. A huge thanks to all the speakers, very rich discussions and very, very interesting. And huge thanks also to a very interactive participants. Really rich discussions coming also in the chat. And on that note, we have for you, we'd like to hear more from you actually. So we have a survey, which let me just share my screen if I with this with a QR code. Yeah. So the question we have for you, and we'd love to hear more, is based on today's discussion, in your view, what type of community evidence would be useful for improving RVF prevention and response? And we have the link here and we have the QR code here. It's also in the chat. We'd love to hear from you and get your point of view on that. Then I'd also like to remind you that the next week's EPI-WIN webinar is an introduction to the WHO Outbreak Toolkit and its applications. So please, we hope we'll see you next week. Huge thanks for joining. And I'd also like to thank all those who were not visible today, but worked very hard to make this webinar a success. My colleagues in the background, and who's not here today for a start. Then we have in the background Tom Moran, Vicky Hussier, my EPI-WIN colleagues, Michael sitting right next to me, Maria Isabella, Lester, and the IT team here at WHO, and last but definitely not least, our interpretation team, who very gamely agreed to join, although this was very organized at very short notice. And we hope to see you next week. Thank you very much. We hope to see you, hope to have your feedback, just as a reminder, on the RVF question here. And this is the QR code. And the link is also here. It's also in the chat, the link. And next week's EPI-WIN, if you just scan the QR code here, and it's also on our website, EPI-WIN website. Thank you once again, and see you next week. Bye.